Good afternoon, everyone. I'm Anil Malhotra, a sports cardiologist based in Manchester, and it's my pleasure to chair this next session along with Professor Megan Wasfi from Massachusetts General Hospital. I'm very much looking forward to the next 4 updates in sports cardiology. And please do, as Michael has mentioned, forward any questions that you have as you've been directed, and we look forward to the Q&A session later. So without further ado, our first speaker needs no introduction, but it is Professor Papadakis, who will be talking about the CRY experience of screening young individuals. Over to you, Michael.
Thank you very much, Anil. So it's a great pleasure, a great honor for me to present to you today the screening experience of cardiac risk in the young. Obviously, when I present the screening experience of the charity, it's important to note that I have a very close relationship with cardiac risk in the young, and I'm very proud to have a very close relationship with such a charity, and have been supported by research grants from the organization. And together with Professor Sanjay Sharma, we've been in charge of managing the overall supervision of the screening program. Now, I'll start with a bit of background to give you a bit of context. Sudden cardiac death is considered a fairly rare phenomenon, although you'll see that that's clearly not the case. But it comes to the forefront every time there is a death or a cardiac arrest of an athletic individual who usually participates at the higher echelons of sport. And that causes significant media attention and interest in the field of cardiac prevention in terms of sudden cardiac death. However, it's very important to highlight that as the charity Cardiac Risk in the Young has been emphasizing for many years now, that sudden cardiac death affects all young individuals, and it doesn't make a huge difference whether you play football at your school or for an elite football organization, an elite team. And based on previous estimates from one of our studies using data of the Office of National Statistics, that number was about 12 young sudden cardiac deaths per week. Now, in terms of the incidence of sudden cardiac death, because that's a question that it's often posed, how common it is highly variable. So if we concentrate on the younger population, those who are 35 or less, the incidence that has been reported is anything between 1 in 4,000 to 1 in 200,000 person years. And I've highlighted the person years here for you because that's an important aspect. It's not 1 in 4,000, it's 1 in 4,000 persons per year. And you'll see on the main studies that I've highlighted here for you, the great variation that exists. And you'll also see a study in the UK in football players that our chair, Professor Malhotra, published, which demonstrated an incidence of 1 in 15,000 person years for young football players, young adolescent football players. The other important thing to note is that a lot of the time, those data sets do not include the individual who survived the cardiac arrest. And obviously, this is as close as it gets to a terminal event, and you'll all remember that episode with Christian Eriksen during the summer football games. And those episodes do not get recorded in sudden cardiac death registries. Now, in terms of the causes of sudden cardiac death in the young, it's important to know what provokes an arrhythmia and can respond to a sudden cardiac death in young individuals. And we can start from inherited cardiac conditions. And here we've got an example of a very thickened heart from hypertrophic cardiomyopathy. Ion channelopathy such as long QT syndrome, catecholaminergic polymorphic ventricular tachycardia, and Brugada syndrome. Connective tissue disorders such as orthopathies. Then we've got congenital heart disease such as coronary artery anomalies and accessory pathways, also known as Wolff-Parkinson-White syndrome. And then we've got individuals who are not born with a condition, but they may acquire a condition such as myocarditis. And here you've got an example of a very extensive myocardial scar and inflammation on a cardiac MRI. And then we've got absence of heart disease, but we can have a blow on the chest, as in commotio cordis, or other things like use of medication and drugs. It's also important to highlight, obviously, that even inherited cardiac conditions don't necessarily manifest themselves from a very young age, and that's important to keep it in mind for later on. Now, how do we go about trying to prevent sudden cardiac death and sudden cardiac arrest in young individuals and in young athletic individuals? Well, there are 4 things that we can actually do. We can investigate high-risk individuals. So I think we will all agree that if we've got a young individual who experiences cardiac symptoms, suspicious of underlying disorder, or they've got a malignant family history, they need to be investigated to ensure there is no underlying cardiac disease. And please remember that cardiac arrhythmias can also present in the form of epileptic fits or even unexplained drowning episodes and unexplained road traffic accidents. The second thing that we can do is try and resuscitate the individual who has experienced sudden cardiac arrest. And that's why we try to expand the knowledge of basic and advanced life support, and in particular, the availability and use of external defibrillators. However, that has significant challenges as well, and ideally, we will, of course, like to avoid that cardiac arrest to start with. And then, unfortunately, when a sudden cardiac death has already occurred, it's very important that the individual undergoes a very detailed autopsy, and if an inherited cardiac condition is suspected, then we proceed with familial evaluation of all first-degree relatives. I think all those 3 are fairly well accepted. However, the problem that we've got is that the majority of individuals who experience a cardiac arrest have not experienced any symptoms beforehand and don't necessarily have a family history. And if we put that in the context of a potential pre-existing condition, that's what has promoted discussions regarding cardiac evaluation and cardiac screening of young individuals. This is actually the protocol that has been proposed by the European Society of Cardiology based on the Italian protocol for young athletic individuals, but it's something that can also be used in non-athletic individuals, and that's exactly what we do with cardiac risk in the young. The protocol has the health questionnaire, physical examination, but really the key is the 12-lead ECG, which can be diagnostic at electrical faults of the heart, such as WBW, angiogeniopathies, and conduction tissue disorders, and can definitely raise suspicion in a significant proportion of underlying cardiomyopathies. Now, there is some experience in terms of the impact of such a screening protocol in the population, and here you've got the experience from Domenico Corrado's group in Padova, where they started screening in the late 70s, early 80s. And you can see here the incidence of sudden cardiac death in athletic versus non-athletic individuals. And what the author suggested is that by screening, they were able to gradually reduce the incidence of sudden cardiac death from 4 per 100,000 person years, so that will be about 1 in 25,000 person years, to almost 1 in 200,000 person years. Now, this is the best study that we've got available, but it does remain an observational study, and to be completely honest with you, I can't say a circumstance that we will be able to get much better data. Now, in terms of the concerns regarding to cardiac screening in the young, there are a few. First of all, people are worried about the low incidence of sudden cardiac death. If it's not too frequent, then how do we identify it? Are we able to treat those individuals? And is it worth going through that entire exercise in a population level in order to prevent a small number of cardiac deaths? The other thing that people question is what's the effectiveness of the screening tools, and in particular the 12-lead ECG. So they're worried about a high number of false positive tests that may stimulate unnecessary anxiety in investigations and elevate costs in terms of secondary evaluation, but also the impact of false negative evaluations. That has an impact on cost, particularly as far as secondary investigations and follow-up is concerned. And the other concern is about the management of individuals identified with a condition and whether it's actually possible to prevent sudden cardiac death. But I think we have come to learn that we can manage inherited cardiac conditions, and things have advanced in terms of both medical and device therapy. And then the last concern is about available expertise. And again, that's something we've been working on for the United Kingdom over the past 10 to 20 years. Now, in terms of cardiac risk in the young, the screening program, it's based on the Italian model. We've got a health questionnaire, a 12-lead ECG, a consultation with a cardiologist, and then we've got available a transthoracic echocardiogram. The ages we screen is between 14 and 35 years of age, and screenings occur throughout the United Kingdom, and that's at a price of about £50 per screened individual. And here I've got some pictures for you, and you can see that we go literally anywhere with our equipment in order to screen young individuals. And these are the numbers that we've been screening over the past 15 years. And you can see that prior to the COVID pandemic, we're reaching almost 35,000 young individuals per year. Now, in terms of the impact of the CRI screening, you can see that we have contributed quite significantly to the improvement of the ECG criteria by reducing essentially the false positive rate from a whopping 13 and 16% in white and black individuals respectively to 1.7 and 3.6% with the international ECG criteria. And here is the international ECG criteria that we should all be using when interpreting an athletic ECG, and it's not too difficult to modify those criteria for the general population. And using such criteria has direct implications, as Dr. Dutia from the CRI screening program has demonstrated, in terms of reducing the request for further evaluation and having a 20% cost reduction with no significant compromise in sensitivity. Now, this is another study by Harshil Dutia in the CRI screening program. This is our most recent publication that refers to the diagnostic yield and financial implications of a nationwide ECG screening. And the poignant points to note here is that that reported on about 27,000 young individuals who underwent the CRI screening. 11% of the cohort had an abnormal screening test, and in most of them it required secondary evaluation. However, that falls significantly by having an on-site transthoracic echocardiogram and has fallen significantly over the years. We had a significant proportion of individuals, 0.3%, that were diagnosed with a condition associated with sudden cardiac death, and the majority of them were asymptomatic and were identified based on the ECG, and that came at a cost of almost 18,000 euros per individual per condition identified, and almost 30,000 euros for a condition associated with sudden cardiac arrest and sudden cardiac death. And very importantly, a significant proportion of them went on to receive treatment. Now, what are the evidence gaps that the current research has identified and has tried to address? First of all, is that there is a continued uncertainty in terms of the overall incidence of young sudden cardiac death in the United Kingdom. And the quotes that we've got, as you saw, are quite wide from the worldwide experience. And that's because of the absence of systematic registries. And then there is an uncertainty regarding the effectiveness of the screening tool in terms of identifying people with disease, as well as ensuring that the false negative rate is fairly low. So the objectives of this study was to determine the diagnostic yield of a nationwide screening program, report on the frequency of false negative results by trying to get outcomes from all individuals and not only the individuals who had a positive screening, and also report on the incidence of sudden cardiac arrest and sudden cardiac death in this screened population. And all of the data formed the PhD of our fellow Hemis McLachlan, who is responsible for all the work that is presented here. So in terms of methodology, we looked at a big population of almost 105,000 consecutive young individuals that were screened over a decade in England and Wales. We excluded individuals who were known to have heart disease prior to their screening. And the protocol was exactly as I described it for our cardiac risk in the young protocol: health questionnaire with symptoms and family history, ECG, cardiac consultation with one of our senior fellows, then selective transthoracic echocardiogram as necessary, and then an outcome in terms of clearing that individual or requesting further evaluation. Now, the sources that we use in terms to get of our outcomes are three. The first one was the NHS Digital, which is a national database that holds data on mortality, hospital admissions, as well as outpatient visits. The second one was actually directly emailed individuals and tried to get them to respond to us and tell us if anything has happened or has been diagnosed after the CRY screening. And the third one was individuals who actually came directly back to cardiac risk in the young in order to inform us of a condition or an unfortunate death in a family member after their screening. And these are the results. So I know this looks a bit complex, but I'll go through it. So almost 105,000 young individuals, and that comes to about 630,000 person years. Out of those, we sent all the data to NHS Digital and were able to match 90% of them, okay? And a significant proportion of individuals were matched for the health questionnaire. The two things I want to highlight to you is that we managed to get data on 98% of our cohort, which I hope you'll accept it's a good result, but there was still a 2% that we did not have any data from either NHS Digital or the questionnaire. The other important points I wanted to highlight is that this is obviously a once-off screening at a particular age of all those individuals. And the last thing is, as I said, a significant follow-up of about 6.2 years and almost 630 person years of follow-up. Now, let's look at our results. The first thing I wanted to point out that out of those 104,369 consecutive individuals that were screened, after they went our screening protocol, the great majority of them were cleared and 2.5% were referred for further evaluation. Now, once they were further evaluated, about 0.43, 446 individuals were diagnosed with a cardiac condition. And as you can see here, there were 0.27% of 208 individuals that were diagnosed with a condition associated with sudden cardiac arrest or sudden cardiac death. And here I've got a list for you in terms of accessory pathways, cardiomyopathies, arrhythmias, and individuals who went on to exhibit ventricular tachycardia or ventricular fibrillation. And it's important to highlight that almost 40% of those 280 individuals actually underwent significant medical interventions beyond lifestyle and medication. Finally, I wanted to highlight that there was a proportion of individuals as well that were identified with minor cardiac conditions, such as bicuspid aortic valves, atrial septal defects, so on and so forth. And although we consider them minor, again, it's important to highlight that almost 30% of them underwent a significant procedure, whether that was an ablation, an ASD closure, so on and so forth. Now, if we go to the other arm, the individuals that were cleared, and try and look at what I will call the false negative results, so the individuals we did not identify, then of those individuals, 222 were identified with a cardiac condition, and 86 of them were identified with a condition associated with sudden cardiac arrest and sudden cardiac death. And actually, 29 of them presented with an out-of-hospital cardiac arrest or with an unfortunate sudden cardiac death. And here again, you can see the conditions in more detail, and you can see the individuals who underwent the procedure. And there was also another significant proportion of individuals who were identified with a minor condition. The other thing I wanted to highlight that those individuals with the major cardiac conditions were identified on average about 4 years after the initial screening test. Now, in terms of all-cause mortality, these are the deaths, 87 of them in total, and actually cardiac deaths were the predominant cause of non-accidental deaths. But what comprise those cardiac causes? First of all, you can see that there is a fairly equal split between sudden cardiac arrest and sudden cardiac death. And that's why you're going to underestimate the incidence of sudden cardiac death, essentially, if you're not counting cardiac arrest. The second point I wanted to make that a significant proportion, about 60% of those arrests and deaths were due to a diagnosed or presumed ion channelopathy, including sudden arrhythmic death syndrome, which means essentially a normal autopsy. And about 20% were due to cardiomyopathies, but you will note that conditions that we know fairly well, such as hypertrophic cardiomyopathy, was absent from this pie chart. Now, in terms of the incidence of sudden cardiac arrest and sudden cardiac death, that was 1 in almost 18,000 person years, or 5.6 per 100,000 person years. And if you try and compare male with female, there was a threefold risk for males, but we couldn't identify any excess risk in terms of athletic status or ethnicity, accepting that the way we defined competitive athletes and the cohort of Black individuals was relatively small for that particular study. Now, the thing I wanted to highlight here for you and I present you the whole diagram is the cardiac arrest. So as we said before, 29 of them occurred in those who were cleared from screening, which we did not identify. But I wanted to highlight that there were also 6 that occurred in people who were referred for further investigations to highlight the potential challenges. So 2 of them did not make it to secondary evaluation because they ignored it or their GP did not refer them. So there needs to be a protocol and a way of trying to get people to that secondary evaluation if they wish to have it, of course. 2 of them underwent secondary evaluation, they were cleared, and then they had a cardiac arrest and cardiac death, which highlights potential challenges in terms of expertise, but also potentially because of knowledge as well, because a couple of them were under regular follow-up and still experienced a cardiac arrest or a cardiac death. Now, this is essentially in detail, and I won't leave that for long because I know there is a lot of data of the individuals who exhibit a cardiac death and a cardiac arrest. I've discussed already the 6 individuals that were positive in the screening. And again, just to highlight that the mean time from screening to death was about 4 years, highlighting perhaps the need for repeated screening in young individuals as it practiced in other countries and as it's recommended by the European Society of Cardiology. Also, just to highlight that 70% of those cardiac arrests happen, unfortunately, during rest or at sleep, which indicates that potentially an emergency response planning wouldn't have saved those lives. In terms of the false negatives, how can we justify them? Well, one of the things is that it may be that the ECG is unable to identify conditions, and we know that. It won't detect coronary artery anomalies, atherosclerosis, aneurysms, and a proportion of cardiomyopathies and ion channelopathies. It's also a fact that some of our knowledge is not still there, and we're still learning about sudden cardiac arrest and sudden cardiac death and the conditions that predispose to that. And that's highlighted also by the fact that 10 out of the 20 sudden cardiac deaths, despite post-mortem and familial evaluation, we still know wiser in terms of the exact cause of death. And then we had normal findings may be explained by variation in test interpretation, and that's we have moved forward in order to get two independent experts to blind review all our ECGs. The final thing I wanted to emphasize is the potential age-related penetrance of certain conditions and potentially the need for repeated screening of those individuals. And here is a nice example of a young adolescent, and this is his ECG at the age of 14, and this is his ECG at the age of 18, and you can see how he has progressed to develop T-wave inversions and indeed a hypertrophic cardiomyopathy phenotype. In terms of the accuracy of the screening test within our program, you will see here that the ECG was the main tool to increase the sensitivity. And overall, the screening program had a sensitivity of about 77% with a specificity of 98%, a high negative predictive value and a positive predictive value, which seems low at 11%, but it is higher to what has been quoted previously. In terms of the limitations of the study, obviously our results represent the minimum incidence of sudden cardiac death in young individuals who have previously undergone cardiac screening, but it definitely highlights that we have been underestimating the incidence of sudden cardiac arrest and sudden cardiac death at young individuals. And this incidence seems higher compared to other studies, but you have to remember that it's pretty comparable to what Professor Malhotra told us, for example, in football players. And you also have to remember that we included sudden cardiac arrest on top of sudden cardiac deaths in our cohort. So in conclusion, ladies and gentlemen, diseases associated with sudden cardiac arrest and sudden cardiac death were identified in almost 0.3, so that's 1 in 370 participants in our screening program, with a further small proportion diagnosed with a condition, on average 4 years after the negative screening. And importantly, 40% of them received a potentially life-saving intervention. The incidence of sudden cardiac arrest and sudden cardiac death is definitely higher than what previously believed, at least in the United Kingdom. And you can see that there is a fairly equal split between cardiac deaths and those who actually survive the cardiac arrest. And the majority of those conditions seem to be with a structurally normal heart due to an electrical cardiac disorder, with 20% due to cardiomyopathies. And very briefly, before I finish, in terms of future directions of the CRY screening program, we try to improve the efficiency and reduce costs in order to increase our capacity by implementing a point-based electronic questionnaire that will not necessarily require the interpretation of the physician, facilitate remote consultations, and try to facilitate by increasing capacity repeat evaluations. There is a potential use of echocardiography that we do ad hoc at this point in time, only to individuals just to have an abnormal screening, to detect those minor conditions that may be making a significant difference. And in terms of data collection and data management, we have and we are proceeding with electronic data sets, secure storage and leakage to national data sets, so I'm able to come back in 5 and 10 years' time and give you data on 2 or 3 times the size of this particular cohort. And also we try to facilitate and standardize secondary evaluation, and that's definitely something that cardiac risk in the young will contribute to in the near future. Thank you very much for your attention, and sorry for taking more of your time, but I thought it was worth presenting the whole cardiac risk in the young screening program. Thank you.
Thank you, and what a great talk. I'm sandwiched here between two cardiologists, neither of which needed